and welcome to the We Talk Health podcast, the official podcast of West Tennessee Healthcare. I'm your host, Kara Mobley, and on today's episode, here with me, I have Dr. Archie Wright. He is a medical oncologist with the Kirkland Cancer Center, and today we are talking about metastatic breast cancer. Welcome to the show, Dr. Wright.
Hi, thanks for having me.
Great. So we're filming this podcast in October, which is Breast Cancer Awareness Month, so we really wanted to kind of get more information, get the word out more on what exactly is metastatic breast cancer. So kind of, I guess, first of all, tell me a little bit about what does metastatic breast cancer mean?
Yeah, so I think in the simplest terms, metastatic breast cancer would be considered breast cancer that has traveled from the original site of origin, the breast, to another site in the body. And that could be to regional lymph nodes under the arm, which most people are familiar with, or it could be what we call distant metastasis, where it leaves the regional area, breast, lymph nodes, and can go to other sites like bone, lung, and liver.
So when we're talking about metastatic breast cancer, many people may be confused. Is it the same as stage 4 breast cancer?
Well, not always. Most of the time when we talk about metastatic breast cancer, we are referring to stage 4 disease. But for instance, if someone is diagnosed with breast cancer and they look at their path report, they'll see the lymph node evaluation. And a lot of times it will say, metastatic carcinoma to the axillary lymph nodes. So technically, if the cancer leaves the breast proper at all and goes anywhere else, including the lymph nodes, it's, technically metastatic, but that would be considered regional metastatic disease, and it wouldn't be stage 4. There are some patients that we have that have breast cancer with nodal involvement under the arm, and it's still considered stage 1, believe it or not. So stage 4 really is when it leaves the breast in the regional area and it goes to a distant site in the body, like I mentioned before, bone, lung, liver, etc.
Right. Now, so is there a time frame? I know that's a big thing of when you catch it. Is there a time frame after diagnosis and treatment that someone might be worried about as far as when the cancer is most likely to recur?
Yeah, in general, these cancers can be tricky. They can come back, at any time. But if you look statistically, the vast majority of recurrences are going to happen in the first 2 to 3 years, and then you'll have another group of patients that will, recur up to about 5 years. The estrogen-positive subset of patients, which we can talk about more in a minute, those patients, have a kind of a more well-behaved, slower-growing breast cancer, but the flip side is those patients will actually have recurrences 10, 15, 20 years later in some cases. Now, that is a small percentage of patients, but it does happen. I've had a few, this year with that exact scenario.
Now, if someone has had breast cancer, what are the ways that they might find out if it's become metastatic?
Yeah, and that's the scary thing is because, people can have metastatic breast cancer and not know it. They can be completely asymptomatic, which is often the case. And then usually by the time it does cause symptoms, then it's already moved to other areas. And for instance, you could have cancer that has gone to the bone and not know it's there until it causes bone pain. If it goes to the lungs, for instance, people can develop a dry cough or shortness of breath that doesn't go away and that they don't have an explanation for. Abdominal swelling, weight loss. There's different things that usually when that happens, though, there's a fair amount of disease that is present and it's, kind of more advanced. So when it's microscopically metastatic, meaning, you'd have to have a microscope to find the cells, that's not going to cause symptoms. So that's what makes it difficult.
Right. So those were some of the signs and symptoms. But again, like you said, there may not be any. Now, what would be the most common types of breast cancer that can metastasize?
Well, first of all, they all can. And I would say that the ones that are most likely to are the ones that are, what we consider biologically the most aggressive. So triple-negative breast cancer, far and away the most difficult breast cancer that we have to deal with. It's very aggressive, grows fast, likes to metastasize more quickly than the other types. So that one is one you would worry about more so than others. Second would be HER2-positive breast cancer. Now, that breast cancer still has a favorable prognosis because the treatment options are so good, but it's still a biologically kind of, again, aggressive, fast grower, compared to the last subtype, which is the estrogen receptor positive subtype. And those are the ones that I mentioned earlier that are lower grade in general, tend to behave less aggressively, grow slower, and those are the ones that typically have those late recurrences. So as far as which ones can metastasize. They all can, but probably in that order.
Now, I know, so if anybody has listened to the radio or watched TV, there's a lot of commercials out there for HR+, HER2 negative breast cancer medicines. What exactly do they mean by those?
There's probably three major things that we look at on the surface of breast cancer cells. And it's important that we look at these because these, whether they're present or not, help determine the behavior of the cancer. So there are two female hormone receptors, estrogen, progesterone. Those are present on about 70% of all breast cancers out there. And then there's the HER2 new receptor, which is present on about 15 to 20% of breast cancers. So most of the commercials that you see out there, when they mention ER positive, HER2 negative breast cancer, these are those breast cancers that are expressing female hormone receptors, specifically estrogen, on the cell surface, and likewise, those same cancers are not expressing HER2 new. So there's a category of drugs out there that are paired with anti-estrogen therapies that are specifically for that subtype of breast cancer. You'll see commercials for Ibrance, Kisqali, Verzenio, and all of those are act in a similar way to augment our standard anti-estrogen therapies. And because they're newer, and because these drugs are newer in compared to anti-estrogen therapy alone, they are marketed heavily and are very effective and have extended breast cancer survival. So you're going to see a lot of publicity with those medications.
Thanks. Yes. So, and when would these drugs be used, or I guess who would these drugs be best used for?
Well, for the most part, they are for stage 4 breast cancer patients. These are patients that have had history of breast cancer and had a recurrence. Now, there are a subset of patients that you can use that are not metastatic. And again, this is getting a little technical, but patients that have 4 or more nodes, have large breast cancers or high-grade breast cancers, there's a subset of those patients where one of these particular medications can be used following their primary therapy, and it has been shown to decrease the risk of recurrence.
And so, if someone is a breast cancer patient, they are maybe interested in clinical trials, what would you say are clinical trials worth pursuing for metastatic breast cancer?
The short answer is yes, always. We frequently will send people out, whether it's for second opinion or if we've kind of exhausted all of our standard of care options, we will send patients to whether it be Vanderbilt or Sarah Cannon Research Institute, both in Nashville. Those are our common areas that we refer. We have some patients that do want to go out of state to places like MD Anderson in Houston, Texas. We encourage it. Patients, when they get through the standard options, know that the options are becoming a little more limited. And so you can access, newer medications through clinical trials who may have, a good track record so far, but their benefit may not be completely defined. And these trials are being used to kind of define that so these medicines can get approved. If you think about all of the good medicines we have out there currently, that's where they started. I mean, all these medicines came out of clinical trials. And so it's very important for patients to be placed on trials, and we encourage that if the patient's willing to travel.
And I know right off the top when we were talking about what metastatic breast cancer is, you mentioned the different ways that it spreads, the different places that it spreads to, either the bones or lungs, liver, or other organs. Do you have, or can you give me an idea of what the possible overall survival rate would be if it's spread to the bones or maybe other organs?
Well, it's going to vary patient to patient, of course. But I would say in general, patients that have bone-only metastasis do tend to do better statistically. People can live a long time with bone mets. I mean, yes, they can cause the morbidity of bone pain and whatnot, but as far as affecting their immediate survival, it tends to not do that as much. Next in line would be lung metastasis, followed by liver and brain. Typically, when you get liver and brain metastasis, the prognosis does shorten somewhat, although there are very effective treatments, in both of those. But it becomes a little more difficult to treat when you have a heavy burden of disease in the brain or the liver.
Right, and I know with the several different types of breast cancer, as you said earlier, everyone responds to treatment differently, but is there maybe a general life expectancy once someone's been diagnosed and is maybe receiving the treatment based on, when they caught it?
Sure. And again, the statistics have to be take them with a grain of salt somewhat, because it's going to include, triple negative patients, HER2 positive patients, estrogen positive patients, which their prognosis varies a good bit. But if you look at all comers when it comes to breast cancer, in general, stage 1 and 2 disease, those patients have a 95% overall survival rate at 5 years. Then you look at the stage 3 patients, it drops down to about 70 to 75% at 5 years. If you have a patient that unfortunately has recurred and has stage 4 disease, in general, they have a 30% survival rate at 5 years.
And would you say, is surgery ever an option?
I'm assuming you mean in the metastatic patient? Mm-hmm. Yes. We don't do it a lot, but there are patients that have, for instance, chest wall recurrences where the cancer just comes back on the chest wall. If that happens and you scan the patient and don't see disease elsewhere, then you can certainly resect, that chest wall recurrence and then maybe follow that with the radiation therapy, sometimes chemotherapy. Other instances or examples would be someone who has a history of breast cancer and maybe they're incidentally found to have a lung nodule on a scan. You biopsy that nodule and it shows recurrent metastatic breast cancer, and you may end up doing a PET scan or whatever it may be, and you do not see disease anywhere else. Some of those patients you can surgically resect the solitary metastasis. And there are other techniques too, like focused radiation therapy and whatnot that we use. But, whether the disease is in the lung or the liver, sometimes those lesions can be resected. And in some cases, not commonly, but in some cases, the disease doesn't show up again.
And I know you briefly mentioned just then radiation. What role would radiation play in metastatic breast cancer?
It is usually palliative. Most of the time with metastatic breast cancer, if radiation is used, it is in the setting of maybe a painful bone metastasis or something like that. Or maybe they have a lesion in, near their airway that's impinging on their airway, and that's one effective way to kind of quickly treat it. If you have a solitary, smaller lesion, our radiation oncologists have a focused technique called SBRT, stereotactic body radiotherapy, where they do very focused, almost kind of pinpoint type radiation techniques, and literally they can do it in 3 days. And sometimes if you have a single lesion and they're able to treat that, you can save them the morbidity of a major surgery and the recovery, thereafter. And sometimes the patients will remain disease-free for many more years or occasionally cured.
Okay, now this is a question I have. As someone who's not very familiar with metastatic breast cancer, and I know I've talked to people in mammography, radiation, men can also get breast cancer. Can men also get metastatic breast cancer?
Absolutely. I have several male breast cancer patients in my practice, and some of them are metastatic. It doesn't discriminate, the breast cancer, so it can travel either way. And basically the treatments are the same, whether it be surgery, radiation, chemotherapy, anti-estrogen therapy, which sounds unusual for a male patient, but if you have a hormone or estrogen receptor positive breast cancer, then one of the treatments that male patient will get will be an anti-estrogen therapy.
And we definitely want to make sure that I just spoke earlier with a radiologist that if a male has any kind of lump or anything around that area, that he definitely needs to get that checked out.
Yeah, absolutely. People think that males can't get breast cancer, but actually,
don't want them to forget.
Yeah, but actually 1% of breast cancers out there are in males, so it does happen, and we see several here at this center.
Okay, and so as far as in West Tennessee, we have the Kirkland Cancer Center here in Jackson. Do you have any last thoughts on what patients or families facing metastatic breast cancer should know?
Well, I would say, first of all, have hope. Just because someone gets a diagnosis of metastatic breast cancer does not mean that, it's immediately terminal. There are people that live very long lives with metastatic breast cancer. There's lots of effective therapy out there with, plenty of clinical trials, new agents that are approved every year. Survival continues to improve every couple of years. The survival rates are going up, and that's because of the effective therapy that we have. So yes, it's scary. It can be devastating to patients, but just know that there are good, effective therapies out there, and you should seek them out.
Great, and that's encouraging to hear. Well, thank you so much, Dr. Wright, for coming on and talking about this very important topic, and especially like you said, we want to get this information out there so that people can get checked earlier or seek help and treatment sooner, and then the sooner the better.
Yeah, absolutely. Thank you.
Thank you so much. Thank you for listening to We Talk Health. This podcast is not intended to replace any medical advice. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions or would like to request a topic, you can reach out to us at wetalkhealthpodcast@gmail.com.